Rahim. I think we have to start the session because we have to keep the schedule. This session will be about the American Academy of Ophthalmology and the International Society of Refractive Surgery. It's our honor to have our special guest, Dr. Richard Abbott, the Vice President of the American Academy, here with us. And he will give us very important talks about the, first of all, the One Network, which is a very important educational program in the American Academy. So welcome, Dr. Richard.
Thank you, Dr. Tamir. Thank you. And welcome and good morning, everybody. And what I'd like to do is to talk to you about the updates in the Ophthalmic News and Education Network and how we use this new innovative technology to improve education for ophthalmologists. Our clinical vice president of education, Mr. Richard Zorab, was instrumental in bringing this to fruition. He received the Guest of Honor Award at the American Academy meeting in Chicago this year and unfortunately passed away from an illness that he had been dealing with for several years, actually at that meeting. So what is the One Network? Its development really represents a revolutionary achievement in advancing ophthalmic education on a global basis and has profoundly influenced education and the care of patients throughout the world. If we look at the background of the One Network, there are now over 15,000 pages of ophthalmic content with over 3,100 news articles and 1,200 videos and podcasts. Almost half of the world's ophthalmologists have logged on to the One Network. There have been over 18 million page views and 4 million visits. So who has access to this innovative educational tool? Well, there are over 31,000 members of the American Academy of Ophthalmology worldwide, so every member has free access to the One Network, as well as it's been licensed through many national societies, and you can see about 48,500 ophthalmologists in 70+ countries. So in this region, in the Middle East, we have some data, and you can see that in some countries it's accessed mainly for the basic science and clinical course, in others for the journals, in others for the clinical guidelines. Here in the Emirates, you can see that almost 4,000 physicians or sessions have logged on to the One Network, and primarily the main use here in the UAE has been the preferred practice patterns or the clinical guidelines. There are more than 1,400 surgical clinical videos and podcasts, including what's called the master class videos, which I'll talk about a little bit later. Also, self-assessments for all of us to learn in each of the subspecialty areas, and a quiz that you can view and learn from called Diagnose This, which is updated weekly and presents interesting clinical scenarios for you to learn from. There are full-text access to now 10 journals, including the Blue Journal, Ophthalmology, the American Journal of Ophthalmology, the British Journal, and you can read the list on the screen. And we look to get more and more journals online. These are not just abstracts, but you can download the full journal articles for free by logging on to the One Network and going to the journals. The clinical practice guidelines are available now in 11 languages, including Arabic and Farsi in this region, but also in French and Spanish and Chinese and Russian, which is not up there but is coming. The Laser Education Center is a new center that was started through the generous donation of Charles Munnerlyn, one of the pioneers in laser surgery. And here, I'll talk about this in a little bit. We also have 3,400 images that you can download, the basic skills course, and additional masterclass videos. The latest version, 2.0, has a search engine with very sophisticated filtering of information so you can find the content very quickly. There's new design and a very modern platform to view your material. And you can customize exactly how you want to receive the information. So if you want information, let's say just in cataract and refractive surgery, let's say cornea, you can streamline this information so that is what you get. So the design is very responsive, so it can be on your main computer or your laptop. It also can be easily configured to your tablet and also to your iPhone or your Droid. So every kind of platform you can receive this and get this information very quickly. The search has really improved, so there's autocomplete. So for instance, if you want to put in cornea and you just type in CO, it'll complete to cornea, or cataract CA, or femtosecond. You put in FEM and it'll come right up to femtosecond. And then there are very powerful filters, so you can filter by relevance or by date, as well as subspecialty content, and also if you want to receive continuing medical education credits. So these little screens that are highlighting just show how you work down a page and highlight one area or two areas that are specific to what you need, and you can actually drill down to a very precise topic and get that information quickly and easily. The image collection is very helpful. Well over 3,000 images, so if you're putting a talk together, let's say on oculoplastics and how to repair a lid, you can download these onto your computer. There's no copyright issues, and you can then incorporate them into your lectures. So in all of the subspecialty areas, there's a wide array of images that are free to use for you or for patient education. Learning plans can be set up, especially if you're trying to learn a new procedure, if you're early in your training, or even if you're an established ophthalmologist and trying to learn a new technology. And you can go, let's say, to cornea and you wanted to learn the DMEC procedure. You can highlight the area, and this will then bring up for you learning various information, including articles, video, master class video, latest from various meetings, so you can get this information. And here you can see a video that is easily downloaded. For the residents, there's a lot of content from what we call the Resident Hub, which is just a collection of information that is put in one place so that a resident, or if you're a program director and you want your residents to learn certain information, you can get this information directly from the one network. The master class videos are very, very strong and very helpful. And most recently, Dr. Steve Charles put on a whole series of videos in vitreoretinal surgery. But there are many, including a master class in cataract surgery by David Chang, corneal transplant surgery, including excellent videos, excellent instructional videos on DMEC, DSEC, DOC, and other procedures that those of you in the cornea subspecialty are doing. There are two new master class in pediatric ophthalmology, one in strabismus and one in cataract surgery, and then, as I mentioned, the vitreoretinal surgery. In the Laser Surgery Education Center, we now have a Pascal simulator that works very nicely for instruction, as well as new cases and courses where you can just simply highlight on the screen, the little cartoon. You can highlight each area, so you highlight the ophthalmoscope and it gives you the reading or the refraction, or you highlight the slit lamp and it tells you what is seen on the slit lamp exam. And you can go through a whole case this way, and it's very instructional. These are the 2014 videos that are available, widely available on the One Network. And again, either these videos, which are captured from Academy members from various meetings, or from the master class. At the major meetings, there are interviews that appear. So at the American Society of Retinal Surgeons and the Glaucoma 360 meeting, there are interviews with the key opinion leaders in each of these areas. You can also interact with these authors. So if somebody gave an interview on latest treatment of exfoliation glaucoma, you can send a message to that author and say, why did you say this, or I have a question about this, and the author will respond back to you. The iWiki is extremely popular. You all know what the Wikipedia is, and we have an iWiki. And this continues to grow, and it's been redesigned. And again, this is all free and available on the education network. The Go Guide is something we're very, very pleased about and excited about. This is the Global Ophthalmology Guide, and you can see a map of the world. And if you look, for instance, in the Middle East region, if somebody wanted to travel here and work or study in this area, they just click on the purple area, and it would bring up what diseases are endemic, what are the prevalence of various diseases, what are some of the customs, language issues. And so it's very helpful for visitors from outside of a region to learn more about where you're traveling. If you're here in the Middle East and you're traveling to Brazil, let's say, you want to know what kind of ophthalmic diseases are most prevalent in Brazil, this will tell you. There's also a whole new ethics center named after one of the past presidents of the American Academy, and those interested in ethics or wanting to learn about ethics, this is a great place to do it. There's the informed consents. We have informed consents for practically every procedure you can imagine that we do. And so these are written, and many of them are translated into other languages. And so you can take these, again, with no copyright information or requirement, and use them in your practice. So what's coming soon? What's on the horizon for the One Network? Well, there'll be new learning centers, new learning plans. The New York Eye and Ear Infirmary are submitting a course on techniques of indirect ophthalmoscopy with a simulator, and there'll even be a pathology atlas. So here the American Society of Ophthalmic Plastic and Reconstructive Surgeons are starting their center, and also a pediatrics center. There will be learning plans in labs in testing in uveitis. There'll be glaucoma diagnostics where you can go and look and help in interpretation of OCT as well as gonioscopy and other conditions. The ophthalmoscopy simulator will be great for medical students and those learning to look at the retina. This will allow all of us to practice and learn about various diseases, as well as the pathology atlas, which will contain virtual microscopy slides, quizzes, and narrated walkthroughs. We don't have time to do a demonstration of the One Network, but we have this available. And this takes you step by step how to navigate through the network. The Global One has an advisory board, just like an editorial board. From this region is Prashant Bhatia from the UAE, and also Dr. Mohammadi from Iran. And every area, every region has several representatives who sit on the advisory board and help with some of the global content. So for more information, you can go online to www.aao.org/ONE. And we also have an Academy table here at this meeting, just outside the door on the right side. And Jane Aguirre, who's the Vice President of Global Alliances, is here with me. And we can certainly give you more information. The One Network, the Academy has spent now well over $10 million in developing this product. It's extremely popular, and if you haven't tried it, you should log on and try to use it. So thank you very much for your time.
Thank you, Dr. Richard. It was very informative about the One Network, which is a very important educational programs on the net nowadays. I'll be talking for about 10 minutes about the ISRS. First, I'd like to thank you for your attendance here for this session, and I'd like to talk as the representative of the ISRS in the United Arab Emirates. Actually, I joined the ISRS about more than 10 years ago, and it was a very good experience working with the International Society of Refractive Surgery organization, because you feel like you are working within your family, and we have a lot of scientific activities, which is very important to enrich and to teach doctors all over the world. We have started doing the ISRS Maghrabi meeting in 2010 in Jeddah, Saudi Arabia, and then we started to we've done the next year the same meeting in Muscat, Oman, and the third year it was in Riyadh, Saudi Arabia. And then we are doing this Maghrabi International Congress with the association or the contribution of the ISRS and AAO in Abu Dhabi, Emirates. Can we run the video, please? I'll show you a very short clip about the International Society of Refractive Surgery. And it will tell you all about the ISRS. This is not the video, the ISRS video, please. This is not the one. Yes.
The strength of the International Society of Refractive Surgery, the ISRS, is being a truly global society where ophthalmologists from all over the world meet, share their information, share their experience.
The American Academy of Ophthalmology is indeed fortunate to have a partnership with the ISRS that provides innovative, quality, respected information for its members and for those attending its meetings.
We have representation of members from over 80 countries internationally. Ultimately, our physicians are a family of doctors.
We can share our experience with other people and in this way help our patients.
The ISRS Multimedia Library, it's a wonderful resource for surgical video. This is one of the best ways to hone your skills as a surgeon, potentially learn how to manage intraoperative complications. And I'm a true believer that video is an integral part of surgical education. There's no substitute for hands-on experience, but it's a wonderful way, and it's an easy way to see how thought leaders from around the world handle surgical situations and can do this in a step-by-step manner.
Is very helpful for a variety of reasons. Detailed preferred practice patterns for cataract surgery and refractive surgery are there. Very extensive information about exactly what are the things to look for pre-operatively and post-operatively, and what are some benchmark standards to shoot for.
And it's a window to bring back that meeting environment and be able to share innovation, share problems sometimes, and have good ideas from clinicians all over the world.
What it allows us to do is to meet with the thought leaders and get a collective approach to how we can better serve our patients.
It's a very well-balanced newsletter, but it's cutting-edge information that can be accessed by members from home or their office any time of day or night.
The Journal of Refractive Surgery continues to be one of the major benefits for ISRS membership. As the leading journal for all things refractive, including lens-based procedures, intraocular procedures, and corneal refractive procedures, the Journal of Refractive Surgery keeps the ISRS membership at the leading edge for all things refractive.
The International Society of Refractive Surgery also sponsors a lot of educational activities around the world, and one that I attend every year is the Subspecialty Day at the American Academy of Ophthalmology, a tremendous meeting that brings together leaders in cataract and refractive surgery from all over the world, and really is something that I find exciting and invigorating, and a tremendous educational opportunity.
One of the great advantages of the ISRS is you have speakers, the best speakers from all over the world, and they discuss various topics in different types of format. This helps to educate and teach people.
Is a unique opportunity to share experience with the most important opinion leader in refractive surgery.
The ISRS for me is a big family, an international family, that shares my passion, which is to provide the best possible care to my patients.
It gave me a chance to share with them my personal ideas and to get access to their help and support throughout my career.
It is truly a global, international society with surgeons from all over the world. And I think this creates the best flow of information to enhance the art and science of refractive surgery. We have a great journal, we have a great meeting, we have a great newsletter, and so now we're really able to do our job to project our mission around the world better than ever before.
Quiero invitarlos a unirse a la Sociedad Internacional de Cirugía Refractiva.
I encourage doctors to become part of the society because it's a family of networking of physicians around the world.
Ευχαριστώ πολύ. Και θα ήθελα να σας προσκαλέσω να συμμετέχετε στις δραστηριότητες της ISRS.
Vljudno vabljeni v organizacijo za refraktivno kirurgijo. Hvala.
أنتهز هذه الفرصة لأدعو زملائي في العالم العربي للانضمام لمنظمة ISRS والاستفادة من المميزات الشديدة التي تقدمها لهم.
Credetemi, è molto positivo e importante che facciamo tutti parte della famiglia della ISRS.
So as you can see here, many of the stars in this video are among us today. They are between us for giving us some of their experience and their knowledge, and will share with us the continuation of the medical education in this region. And as mentioned before, we have the American Academy ISRS booth next to the hall on the right side. Jane Aguirre there will be happy to help anybody of you. Back again to the continuation of our session. As surgeons and doctors, we all have errors sometimes, but we are all concerned about patient safety in the first issue. And of course, reducing the medical errors is a very important issue in practicing surgery and medicine. So I'd like again Dr. Richard Abbott to talk about the reducing the medical errors and improving patient safety is really a global thing, so it's a global initiative for ophthalmology.
Thank you. This topic is actually a very important topic for all of us who are looking at what we're doing in surgery, and especially as we innovate in our profession. And I became interested in this in my work as Secretary for Global Alliances for the Academy, and also as past chairman of the board of the Ophthalmic Mutual Insurance Company, which is the medical malpractice company for the American Academy of Ophthalmology, and also in my past work as chair of the Clinical Guidelines Committee for the AAO and current chair for the International Council of Ophthalmology. So if you go to Wikipedia and you look up the definition of patient safety, basically it's now defined as a new healthcare discipline that emphasizes the reporting, analysis, and prevention of medical error or mistakes that often lead to an adverse event. Recognizing that errors now impact 1 in every 10 patients around the World World Health Organization calls patient safety an endemic concern. It is very significant. So when did we as doctors really start paying attention to medical error and patient safety? Well, from 2000 to 2009, this was called the decade that changed the world. And you can think back on that decade of everything that's happened. But also, from the medical profession, it's also the decade that started us seriously thinking about the mistakes that we make and how can we do better? How can we improve them? Looking at data from the US in the reports from the Institute of Medicine that were published in 2000 and 2001, about anywhere from 44,000 to almost 100,000 deaths per year occur just in the United States from mistakes, and that more people die from a medical error than from cancer or from airplane accidents or motor vehicle accidents. In looking at the literature here in this region, there's a nice paper that was published in 2013, Factors Shaping Patient Safety Management in the Middle East Hospitals from the Nursing Perspective, a focus group study. This actually was published out of, from author in Egypt and also from Saudi Arabia. In 2014, last year, there was a major conference here in Abu Dhabi on patient safety and quality and looking at how things could be improved. And coming up in 2015, there is a conference that will be just in about a month and a half or 2 months from now here again. This one is in Abu Dhabi on Patient Safety and Quality Congress, and also one in Dubai in October 2015. So clearly in this region there is a lot of new and renewed interest in this area. In Europe, in 2008, there was a consortium of European Union Network for Patient Safety, and also the Improving Patient Safety in Europe Consortium, which met in conjunction with the Health Agency in Bologna, Italy. This was in 2009. And then just last year in Rome, a major initiative on patient safety, state of art, and perspectives in Italy. And you can go around the globe, and this really is beginning to pick up traction and get a lot of attention. So the question I ask everybody in the audience is, how concerned are each of you, about mistakes occurring and about patient safety issues, particularly in the work that we do in ophthalmology? Well, think about that. For the patient, when the term medical error is defined, 50%, one half of patients thought that errors were made often and that most of them could have been prevented. In fact, there have been several books published, again in the United States, but you can go around the world and find examples. Here in 2003, A Wall of Silence, about the untold story of medical mistakes. The New York Times, in their New York Times Sunday magazine, wrote, "Half of what doctors know is wrong." More books. One of my colleagues at the University of California wrote, "The Truth Behind America's Terrifying Epidemic of Medical Mistakes." Another book in 2010 on medical error. And then Time magazine had this as their page, front page. What doctors hate about hospitals. All of us at one point in our lives either have been or will be a patient. And what we are concerned about is a mistake being made on us. So what is the outcome? What is the outcome for the patient? Well, the outcome for the patient is loss of trust. We as a profession are losing the trust of our patients because there is a lot of publicity. There is more and more data showing that indeed 10% of patients have a mistake made. And if you go on Amazon, go on the internet and just put in patient safety, you will find pages and pages of books in every language on medical error and patient safety. Not sure why it's going out. Okay. If we look at the healthcare industry compared, let's say, to the aviation industry, we are actually quite far behind. And there was a recent book published called Beyond the Checklist that looks at medical error and compares us to what goes on, for instance, in a cockpit before the captain of the airplane takes off. What do they go through? And if you look at this statistic, how hazardous is healthcare, and you look at dangerous, regulated, and ultra-safe, you can see in red that healthcare is at the same level of safety as mountain climbing and bungee jumping. We are at the extreme, and that railroad travel, chartered flights, airline flights are far more safe. So, as the politicians would say, yes, we can do better. And what I'd like to talk to you about is some initiatives that are going on not only in the United States, but around the world on how we, in particular ophthalmologists, can do better in minimizing mistakes. One of the problems is reporting of a medical error. If you report a medical error in the US, often the lawyers will be there and the patient will sue you. And so it's difficult when there is a mistake made to admit that you had a mistake. In fact, on CNN, the chief medical correspondent reported back in 2013 that 90% of medical errors are not reported by hospitals. And in another report, that 1 in 7, only 1 out of 7 errors are actually reported. So why is this? Well, it's really one of shame and blame. If we make a mistake, if we put in the wrong implant, if we make a mistake operating on the wrong eye or whatever, we're ashamed. We feel terrible. And everybody is pointing a finger and said, you made a mistake. And so it's very difficult to admit that mistake. And then on top of that, we have the legal and medical legal implications. So let's look specifically at outpatient errors, because that's what we do as ophthalmologists. Everything we do pretty much is in an ambulatory surgery setting, is in our office, is not in the hospital. So if we look at that, we really want to look beyond the data for hospitals. And let me concentrate on that. So we can break this into three areas. One is mistake in diagnosis. Another is one in prescribing medications. And three is communication. What we tell our patients, inadequate informed consent, where the patient really doesn't understand what is being offered to them. And there are many articles that show that about 1 in 20 adult outpatients are misdiagnosed. Here's an example just from our own clinic where you can see on the left classic dendrite for herpes simplex, and on the photograph next to it something not so obvious, but again another herpetic patient that happened to be treated with steroids because the diagnosis was missed. On the bottom part, there's a photo of a classic endophthalmitis. And then on the lower right, not so classic endophthalmitis that was mistreated, and ended up with an enucleated eye as that situation got worse. With prescriptions, doctors' handwriting can be very difficult to read, and there are many medical errors reported by the pharmacy, and even the pharmacists make mistakes. And now, even in the era of electronic health records, just hitting the wrong button or prescribing the wrong medication is not that unusual. And then finally, communication, as I mentioned, either inadequate communication or misunderstanding of what we're saying, and especially with a lot of the new technology in trying to understand femtosecond versus traditional phaco, what are the advantages, disadvantages, sometimes difficult for the patient to grasp. So there are approximately 300 outpatient visits for every one hospital admission. So the exposure for medical error, for what we do in our outpatient clinics, is huge. And they occur every day in our offices, in the ASCs, in nursing facilities, and other places of outpatient care. Can you advance the next slide, please? Thank you. If we look at the cost here, that 52% of medical liability claims are related to ambulatory care. So from a medical legal perspective and a financial perspective, it's significant. So we have a unique opportunity as ophthalmologists to do better. So what we did was we started a study years ago, and I've continued through analysis of medical legal claims to learn where we make mistakes and to then create recommendations through risk management. And then link these recommendations to clinical guidelines, or the preferred practice patterns, or the ICO guidelines, or any guidelines that we may use, and make recommendations for performance measures. Claims data actually are a representation of what we actually do and where errors are possibly made. So a patient, if we have a poor outcome following cataract surgery, it may just be a poor outcome, or it may be a mistake. Something happened in surgery that didn't go the way it was supposed to go, and on some level it could be considered an error. So the goal of the claims analysis was to improve patient safety and provide data for guidelines that reflect what we do in our practice and ultimately reduce medical error and reduce the frequency and severity of the lawsuits. So let's look at claims data as a reflection of what we're doing in our practices. And this is data now, about 27 years of data collected from over 4,500 ophthalmologists in the United States. It's the largest database of medical malpractice claims probably in the world. So if you have a medical malpractice claim, typically you're in surgery, something bad happens, patient calls you on the phone, is upset, they may ask you for their medical records, and then they get sent to an attorney, and then you get a letter in the mail or notified that you're going to be sued. If you're going to be sued, you're depressed, you're upset, and you get on the phone and call your lawyer or call your medical malpractice carrier, and the process is started. And this is pretty similar in most countries. If we look at data from 2014, and if you practice for 35 years on average, you have in the United States a 95% chance of having a suit filed against you. 95%. When I show this to the residents, they all get depressed. They said, that means sometime in my life, most likely, 95% chance, I'm going to have a lawsuit. The only good news is, and that's true, the only good news is that 50% of those claims are either thrown out or nothing is paid. So that's our only consolation. So your goal, my goal, our residents' goal is to be in that 5% and hopefully increase that number so less get sued. So let me just share with you some very interesting data that's not published, but is very interesting by specialty. And the upper left is cataract. We can look at cornea. We can look at pediatrics, strabismus, refractive surgery, glaucoma, oculoplastics, retina, and comprehensive ophthalmology. So if you look at frequency by specialty, it makes sense that the most lawsuits will occur against cataract surgeons. And that is because that is what most of us do, whether you're a comprehensive ophthalmologist or a cornea specialist or a refractive surgeon, almost all of us will do cataract surgery. So a higher number, more exposure, more cases against us. I'm very pleased to say as a cornea specialist that the fewest claims are against cornea, and even refractive is pretty low compared to the way it was 10 years ago. But if you look at severity, severity is how much money is paid for damages to a patient. Retina has the highest in this group, and you can see cataract is down near the bottom. So not that much money paid if there's a lawsuit in cataract surgery on average. And actually for LASIK and refractive surgery in the US, that number continues to go down, which is good news for all of us doing refractive surgery. But if you look at severity for pediatrics, you can see that this is very high. So low frequency, pediatric ophthalmologists get sued rarely, but because of ROP, retinopathy of prematurity, and because of the lifelong damage to the eye, the damages can be very high, in the millions and millions of dollars. And if you look at the top 10 claims of money paid out, 7 of the 10 out of tens of thousands of cases are pediatric, usually ROP or related to pediatric because of a lifetime of a child if there is damage to their eye and the ensuing blindness for life. So what do you do with this information? What is the next step? So what we did was we took this information and we added it to the body of evidence, evidence meaning from the peer-reviewed literature when we form a clinical guideline, to look at what we are doing as ophthalmologists and link these to the clinical guidelines. And when we talk about improving quality of care, we're talking about 3 elements: structure, process, and outcomes. Structure is where we practice, process is what we do to the patient, and outcome is what happens to the patient. So let's look at process and structure. And let's look specifically at LASIK, and let's look at the data from LASIK and what we've learned over the years and why the number of malpractice cases in LASIK have dramatically dropped in the last 10 years. And for all of us who do refractive surgery, that's a huge positive piece of information. So we analyzed from 1998 to 2008, 242 claims with a peak in 2001. So this is in the relatively early days of LASIK, and we were learning a lot. And this is the algorithm for a claim, which we talked about before, but Winston Churchill said, however beautiful the strategy, you should occasionally look at the results. So we wanted to see what we were doing in LASIK, where the medical errors were occurring, and how we can make them less. So what have we learned from the analysis? Well, we learned that from a system perspective, we had cases that had wrong laser settings, we had laser malfunctions, we had issues with co-management where the surgeon wasn't caring for the patient, somebody else was and making mistakes. There were communication issues, mainly unrealistic expectations by the patient, poor patient selection, choosing patients, let's say, with forme fruste keratoconus, informed consent issues, and inadequate documentation on the medical record. In the process area, we had surgeons who weren't well trained in the surgical technique. Their preoperative assessment was poor or inadequate, not recognizing, for instance, potential for ectasia, and possible effect of comorbidities, patients with glaucoma and other issues, and also management issues. So what did we do with this? We took the preferred practice patterns on LASIK, and we added to the preferred practice patterns all of these pieces of information that added to the literature that was already there. And all the red arrows show what we've learned from the literature and from our malpractice claims analysis that we added to our clinical guidelines. So we built that bridge between the claims analysis and the preferred practice patterns, and then those got distributed to all our members. Briefly, let's look at cataract surgery. There are mistakes in power, in size of the IOL, and the type of the IOL that you wanted to put in, the positioning, and even the wrong eye operated on. So we needed to put safeguards in place, and we used the timeout, where before anything starts in the operating room, everything has to stop, nobody can do anything, and the patient, the eye, the IOL, everything is identified and confirmed. So the question then is, what proportion of real mistakes are we possibly missing? Because maybe everybody doesn't sue, and you can make a mistake, and we don't have that data. And do these errors represent things that we as physicians or ophthalmologists are doing wrong, or are they part of the system that's not helping us? In other words, where we practice. So we need some data, and we need to look at outcomes. And as Lord Kelvin said in 1880, if you can't measure it, you can't improve it. So we need to be able to measure and get some more data. So the Academy started just this past year in March of 2014, the IRIS Registry, which is to improve performance and outcomes of ophthalmology. This is the Intelligent Research in Sight. And what this is the first comprehensive eye disease clinical registry in the US, and enables ophthalmologists from every practice, including academics, to use clinical data to improve eye care delivery and patient outcomes, and then uses a valid and HIPAA-compliant method to collect this data from patient records from the electronic health record. So there are a lot of reasons why we like the IRIS registry, but one is for continuous quality improvement. So the registry will be easy to use, timely, and responsive to the needs of our profession, and that is showing to be true. So the individual ophthalmologists own their own data. There are protections in place for discovery of MD-specific data, so it cannot be used against you in a legal case. And each of us give permission to have our data distributed and reported in a group effort. And the Academy owns the aggregated data and reports. So this, as of the end of the year, over 1,000 practices have signed into the IRIS registry, over 4,000 ophthalmologists. Look at this database. 10 million patient visits, 4 million unique visits. There is no clinical trial, there's no database anywhere that has bigger data than this. So the impact of aggregated data, or what they call big data, can't be underestimated. And I think what you'll find from a research point of view, as well as improvement of clinical practice, will be huge. The aggregated data will allow us to identify which IOLs are better, where the complication rates are. It'll help us answer the question about femtosecond laser and traditional phaco, and many other clinical questions. So attention to reducing medical error is now on the radar screen of many countries around the world, and even in the developing world, and has become a priority of national societies and health departments and ministries of health. A report from the WHO shows that medical errors affect 1 in 10 patients. NGOs and other non-governmental groups that are involved, there are a huge number that are available that you can look up on the internet, but this topic now is becoming global on every agenda of every health department. I go to Beijing once or twice a year. I've been doing this for years, and working with the Ministry of Health with a patient safety conference. Aravind Eye Care System in India and Madurai also has a very high priority of patient safety and have many of these initiatives in place to reduce medical error. So just in summary then, a few quick points. Patient safety knowledge continually enhances our improvement efforts, and we can apply lessons that we've learned from business and industry, in particular the aviation industry. And as we adopt innovative technologies, we also adopt ways to minimize mistakes. We need to educate all of our doctors and our patients, and we need to enhance error reporting systems. And then by doing this, create initiatives or incentives for more dollars, more money. The US now has created this incentive, and for our elderly, for our Medicare patients, if you can demonstrate safety and quality, you get paid more for your surgery. So there are 3 pathways to improving patient safety that I've talked about. One is using the evidence from medical malpractice claims as an additional resource for populating the clinical practice guidelines. Another is by increasing transparency in healthcare through legislation designed to improve patient safety and not to punish, not to shame and blame the doctor. And third is to collect data to demonstrate outcomes through instruments like the IRIS registry to improve quality of care. So our general principles is we need to recognize the problem, we need to understand the magnitude of the problem, quite big. What are the causes of the errors? What do we do to fix the problems? And then future technologies and solutions. So the definition of insanity is doing the same thing over and over again and expecting a different result. And so this is what we've been doing. Now we're changing. We're trying to look at better ways to decrease medical error and improve our outcomes and quality of care for our patients. Thank you very much for your attention.
Thank you very much, Dr. Richard, for this very informative things about the medical errors. And I think that, as I mentioned before the lecture, that our aim as doctors and surgeons are patient safety, and of course, by reducing the medical errors, the safety of the patients becomes more, and both doctors and patients will become more happier. But I have a question for Dr. Richard. Do you think that it should be taken into consideration the errors which happens from the patients themselves, even if you have given them good instructions and proper communication between them about, for instance, the post-operative treatment or recommendations or something like that? Sometimes they don't follow up, or is this taken into consideration as well?
Yes, it is, and I think part of this is the communication issue, is knowing that if a patient is not going to be compliant, or you're worried about it, to have everything in writing, to follow up the best you can. But sometimes we do everything we possibly can for the patient, and they still don't follow our instructions or directions. We need to document this. And I think at this point, nobody has figured out how to do it better to make our patients more compliant, other than giving them as much information and as much knowledge to know that if they don't follow directions, maybe they're at a risk for infection or other problems. But this is a good point, and sometimes it is out of our control.
And I think with the modern technology and the use of the internet and these things, we might have a way or a method so that we can even block these instructions for the patients at their homes. So if they have any problems or any doubts, to be there with them, or they can communicate easily, so that even the errors, medical errors of their problems will become less and less.
Yes, so and I think if you have systems or ideas about this, I would love to hear about it, because we're always looking for new, innovative ideas to help better educate the patients as well as ourselves. So thank you for that comment.
Thank you. Thank you. Yes, Dr. Safwan.
How can we record the patient's non-cooperation as a recording? For example, we are putting all our instructions on a base of cardboard, papers, and so on. And we are saying that in all the file records of the patient that they are being instructed in a clear way for the use of medications, that they shouldn't do this and that and that. But how can we record that that patient will not cooperate in the right direction, that what we plan for? Because that's very important.
Yes.
Because now, when that patient, that he's not cooperating in this way, and he will claim, in any case, let us say, for example, the most popular things, endophthalmitis. Now, infection can happen in that way. Now, that's right. We are isolating that microorganism, and we can match with everything. But cooperation to be recorded from us and to be put in the records going to the committee, that's another issue. How can we do it?
Well, the best you can do is to document what you've said to the patient, or the material that you've given to the patient, and there's no way to document then how the patient then follows your directions and does what you said they're supposed to do. So you should have a very clear system of what you want to communicate and what materials you give to the patient. And the other issue is, if you're doing elective surgery, and in your informed consent or in your interaction with the patient, and I often rely on my staff, because the patient reacts differently to us as physicians versus our staff, who maybe screens the patient. They get a different sense of their personality and who they are. And especially in refractive surgery, at our university, in our department, when I was head of our refractive surgery, we turned down about 30% of the patients who come to see us, because we felt that either their expectations were inappropriate, or we felt that we could not rely on their ability to follow our instructions. They were too cavalier to, they're going to have the surgery and then they're going to go swimming 2 hours later. And we just said, this surgery is not for you. We're not going to do it. So it's a difficult situation, but we all try to do the best we can. Hello?
Thank you. I think that's a very important subject. And we started embarking on this quality improvements more than 15 years ago. We started quality assurance, quality control, quality management. And we've seen the benefits. Our patients appreciate the change that happened over 15 years. But the most important problem that we have is that I cannot find a solution for this is, like you mentioned, the physicians reporting. And you showed the problem very well, but you did not emphasize on how we're going to deal with this. You mentioned that you're going to give them incentives, dollars, but even this doesn't work. So how did, in your experience, how can you engage the physician for more reporting within the system?
Well, there's two ways that all of us as human beings operate. One is, we call it the carrot and the stick. One is, there's a rule that says, you do this or you will not be certified, you cannot practice, you will not get paid, and that's the stick. The carrot is, if your practice or your clinic or your group has very low incidence of mistakes or complications or medical errors, that you get special recognition either by the government or by the health agency or by the local group or whatever, that eventually that brings you more business because your group is safer or has less errors. But it really fundamentally comes down to human nature and what drives us to do things. It's like ethics. We teach people ethics. If you're born unethical, no matter what class you go to, no matter what we teach, you're still going to be unethical. And I think in this way, it's similar in some regard. So in the US, we now have our Medicare. If you report and you show that you have quality initiatives and certain things in place, you get paid more money. That is one incentive. On the other hand, if you have less mistakes and you do better, you also get maybe a recognition of some kind that will help your marketing and help bring more patients to your clinic. So I think right now those are our only ways to do this. Yes?
As they say, if there is a family problem, there is two parts, the wife and the husband. But I think in these problems that we have three parts. And maybe you, Ms. Virgin, the doctor and the patient and the other doctor. You know that 10 of the problems that we have before the claiming in the suit or something, there is problems come to the doctor in his clinic without going to the suit. And the most of these problems coming from the other doctor. And this is very important point, doctor, because you know that if any doctor want to make a problem for you from one patient, he can do it. For example, if I did a LASIK surgery, I am LASIK, for a patient who have 7 degrees, and he can see 6.6, but he have 0.5 astigmatism, and go to the other doctor, and he will say like this 0.5 astigmatism will be a medical error. Okay, maybe when the patient doing the claims or suit, he will not touch you, but he will make a good headache for you through the patient. So there is a very important points in this is as you say, doctor, the ethics of the doctors. for the others? Maybe, I don't know if this is...
Well, this point is very important, and it's something that we see all the time, especially in a community where there are competing surgeons, and you do good surgery, and the patient expectations, even though you said 6/6, but there's 0.5 of astigmatism, for most of us, and what we would tell the patient is that that is a good outcome, and that is an excellent outcome. But maybe in the patient's mind, because their expectations were they were going to have absolutely perfect, however you want to describe that, vision, they go see somebody else, and this other doctor says, you know, you still have a residual astigmatism, it is not perfect, and the doctor who did this didn't do a good job, and says something negative. And that is very difficult. I mean, we see this everywhere, all over the world. And we teach our residents and our doctors that, you know, that this is something they shouldn't be saying or doing. Even when I see patients in my referral practice where somebody did make a medical error and there was a broken capsule and there was a piece of nucleus sitting on the retina and there's things that maybe could have been handled a little bit differently, I never criticize the other doctor. What we teach is the focus as a consultant is to support and help the patient and focus on the problem, not on trying to guess what happened at surgery to your colleague at the time. So these are important issues, and I think, again, they require a lot of discussion. And a lot comes down to just the nature and the human nature of the doctor and their ethics and how they're going to behave in a community. And some things we just can't control.
That's true. So it's a very complicated and intermingled thing at the same time, patients, doctors, community, and ethics in general.
Yes.
Thank you again, Dr. Richard, for this very important lecture. And I think we concluded our session by now, and I regret to inform you that the court, the last part of the part, will not be able to do it today. Maybe we'll try to do it on Saturday with another session. So thank you for your time here in this session. Thank you.